Good evening, everyone. Welcome to the Shape the Future of Vision webinar by Euclid Systems Corporation. We are very pleased to have you join us tonight for the first webinar in a series of 4 we have planned for this year. I know you'll find the information exciting and useful to you. First, I'd like to start out by introducing myself. I'm Jane Beeman, and I am the Global Director of Professional Relations for Euclid. I'm going to tell you just in a few minutes, a few short notes about who Euclid is. Euclid may not be a common name known well in North America. However, Euclid is over 30 years old, a company with a focus on improving the lives of patients with myopia. Euclid has provided more ortho-k lenses to eye care practitioners annually than any other company, therefore achieving the position of the global leader with nearly 2 million lenses on eyes around the world. While Euclid is a U.S. company, the focus after its original approval with the U.S. FDA in 2004 was to focus on China and Asia, where myopia incidence is extremely high. From those learnings and that perspective, we've now begun to expand our focus into our U.S. market. We received China FDA approval in 2007. We became the first U.S. produced ortho-k lens to be approved by both Japan and Taiwan. And we are proud to be the first U.S.-based ortho-k company to have our own wholly owned Chinese subsidiary. Now, many of you on this call may know me. I have over 35 years of fitting specialty lens experience. But I want to tell you that ortho-k lenses and the Euclid design has a long history of very sophisticated designs. Our Myopia lens design gives us the opportunity to align these curves and use an empirical, straightforward fitting protocol. You don't need a trial set. There's no need to purchase a large inventory of lenses. The unique algorithms that have been developed by Euclid over the 30 years have shown in clinical results to have a very high success rate and achieve in just a couple of office visits a high level of success with patients. Euclid is also pleased to provide you with a proprietary state-of-the-art manufacturing process to ensure it's the highest quality product and absolute reproducibility. We are an FDA-approved company, and we are proud to be a United States manufacturing company. Now, I have to take a moment to explain to you that this presentation, while sponsored by Euclid, expresses the opinions and use of contact lens products as utilized by licensed eye care doctors. It may not reflect the FDA definitions for orthokeratology or the specific approved use of our Euclid product. It is the opinion of our welcome guest speaker. I want to thank you again for your participation. As someone who has spent many years in clinical practice, I know it's difficult to take time away from your practice or your family to spend an hour and a few minutes with us tonight. But I know you're going to find this well worth in learning and experience. So let me begin by introducing tonight's speaker. Dr. David Kading is the CEO of the Specialty Eye Care Practices with 3 locations in the Seattle, Washington area. Dave is also the co-founder of the Optometric Insights online portal for progressive practitioners. Dave and his practice has been recognized as one of the top influencers and some of the best practice in eye care today. His progressive and forward-thinking approach to eye care has resulted in many new and fresh perspectives on today's practice. Please join me in welcoming Dr. David Kading.
Well, thank you so much. I'm obviously very honored to be able to be part of the webinar tonight, and I know that this is very exciting for me because myopia has been a big part of my practice dating back to my residency, which I did at Pacific University, and am really excited to share my perspectives with you. Before we begin, I was hoping that we could do a quick little poll here of everyone's experience with orthokeratology. So let's go ahead and launch that poll. And if you wouldn't mind just sharing your perspectives of where we're at and how you're using orthokeratology. I'll give you about 20 seconds or so to answer these questions. Okay, we're still getting a couple of responses in here. I'll give you just another couple of seconds. Okay, we'll go ahead and launch the rest of the presentation, but what it looks like is about 55% of you are currently fitting orthokeratology, and about 35 are fitting the Emerald, and 43% are CRT. So great. We'll go ahead and launch into the presentation. If we could click over to my slides, that would be awesome. All right. So I'm not entirely sure. Is everybody seeing my slide presentation? Okay, here we go. So this presentation is kind of all about proactively managing myopia in our practice. And essentially, I'd like us to have three major takeaways from the presentation. One is that myopia is a disease, and that it's a far bigger issue than we're really making it out to be, and that orthokeratology effectively manages myopia, and orthokeratology can be simple. As I've traveled across the world and spoken to thousands of practitioners, I've always had this scratching sensation in the back of my mind as to why are we not fitting more orthokeratology? And I really think that the major reason for that is because the process has become overcomplicated, and it's something where the practitioners don't find it to be simple and streamlined. In my practice, I've always looked for what's the most effective way that we can become successful with 80–90% of our patients, and to do it quickly and seamlessly. So I'd like to thank Euclid for allowing me to share my perspectives on myopia. Anytime we have a platform to present material that we're passionate about, we're always grateful. So very thankful for Euclid and what they're doing for the world of myopia today. So I'd like to share some statistics. Many of you have seen some of these statistics, and some of you may not. And I think it just goes to present that we as a population have this perspective that myopia is a refractive error and it's a nuisance, rather than this is a disease and it is progressive and it is a very big problem. Back in the 70s, myopia accounted for about 25% of Americans. And now, as of 2004, it was 41%, and that's rising. So nearly 50% of the US population is myopic at this point. It's a little less than that, but it's very, very prevalent, and it is far bigger of a deal than we make it out to be. The prevalence of myopia in Americans has soared by 66% since the early 70s. And as a parent, I think I can, relate to many of you, is that we want our children's future to be lined up, and we don't want to be thinking about anything being wrong with our kids. Now, obviously, with us as parents, we're going to certainly induce some things that are not optimal into our children's life. But if there's any way that we can slow or stop or help a progressive condition, obviously that's our goal and that's our strategy. And as a family that has a baby, it's traumatic for a parent to all of a sudden realize that their child isn't able to see. And I think as clinicians, oftentimes we pass that over and don't really realize the impact that it is having upon the family's life. But myopia is prevalent very, very readily around the world. 75% in Singapore, 80% of the population in Hong Kong, and in other places on the planet, it's as high as 97%. So I want to make sure that the webinar is clicking through accurately. Can somebody jump in and let me know, is it progressing here correctly? Are we having some technical difficulties?
Hi, Dr. Kading. We're going to restart the share. Looks like it got stuck on one of your slides.
Okay, so do I need to go back? Did everybody hear everything, or? Okay.
We don't hear, so I'm just double checking. There we go.
Okay, so we heard everything, but we didn't see everything.
Yes.
Okay. Let's see if we can.
Okay. Give me one sec. Okay, I'm giving you control back now.
Okay, so I don't think I have control over the PowerPoint that you're viewing. This is not. Sorry, everybody, for these technical difficulties here. There. Are we seeing my screen now?
Yes, sir.
Okay. So as I was saying, in places like Singapore, it's 75%, Hong Kong, 80% of the population, and in places like South Korea, 97% of the population has myopia. And in certain places in the world, 90%, in China, of the Chinese students with schooling have some sort of nearsighted refractive error. And what I love about this is that from the perspective of the government and the schooling officials, they're seeing this as a major epidemic. We don't see it that way in the United States. They're developing whole schools around how do we alter this myopic epidemic. These children here are being altered in their working distance from their eyes in order to reduce the visual demand. In the top left-hand picture, they're trying to bring more daylight, more sunlight into the classroom in an effort And although we don't necessarily have any evidence of this, this school even goes so far as to take these massage breaks for the children to try to reduce the stress that is on their eyes. And we know that myopia worldwide is going to continue to be a major issue. By 2050, we're seeing that 2 billion people worldwide will have progressed to 5 billion that have had myopia. And I think what's most interesting about this study by Flitcroft is he's showing that, and this is in millions. So sorry about the graph, but 1 billion people here will be high myopes by 2050. And the impact that it's going to have on public health is going to be significant, particularly if 50% of the whole world's population is myopic. When we look at risk factors for developing myopia, if both parents are myopic, you got a 6-time risk factor. If one parent is myopic, it's 3 times, and your risk factors are pretty low if neither of your parents. And we've, looked at, well, how do you develop myopia? And, over the years, we've come to realize that your risk of developing myopia is far less if you spend 2 hours or more a day outside. Now, that number does not necessarily hold true if you already have myopia to reduce the progression in some of the studies. But an interesting study that was done by Leslie Donovan in China found that myopia progression is 60% less in the summer than in the fall and winter. And I think that just speaks to we have a lot to learn as to why this is happening and what can we do. I think the takeaway that I always have from this is to scoot my kids outside and to recommend my patients just spend more time outside. And is there anything that we can do? I think that's just good for their mental health as well. But we still have a lot to learn with regards to the progression and the progressive effects. Overall, we also know that a kid who becomes myopic younger is going to have a far greater risk of developing high myopia. There's a lot of studies that are out there that show the progression is far faster the earlier that a child is. But I think that oftentimes myopia gets missed in the 4, 5, 6, and 7-year-olds because their vision just is that way. And they, maybe haven't had a visual screener at school. And there's a statistic somewhere around 90% of kids with visual problems get missed in school vision screenings because the screenings may not be challenging enough, or a lot of schools have just done away with vision screenings. And unless they're getting an eye exam on a regular basis, and a parent doesn't really know to have an eye exam if they don't know that their child is not seeing well. So a question I oftentimes get asked is, when do we start worrying about myopia, and when do we start thinking that this is a problem? Well, emetropia is normal at 6 to 8 years of age. And as you remember, the emetropization process is leaving most patients, most of our kids, hyperopic until they reach about 6 or 8 years. And once they reach that age, we would hope that they would stay emetropic for the rest of their life. And we used to think that maybe a little bit of myopia, maybe a diopter or a diopter and a half, was a great thing, because then when they became presbyopic, they would be able to see up close and not have to wear their glasses for reading. And I think as a clinician, that's what I used to think, but coming to a realization of the risk factors has kind of changed my perception in that. And definitely if we see myopia prior to 8 years of age, it's not normal. And those kids are very likely to progress in their myopia, and not just progress, but to progress very, very quickly. Most clinicians will consider about a half a diopter increase in the prescription to be progression in myopia. Granted, we could see some patients progress by a quarter and then go plus a quarter of the next year. Unless you're doing a cycloplegic refraction, maybe that accommodation is fluctuating a little bit. But, in our practice, if we start to see a quarter or a half a diopter of increase, we start to get concerned and say, hey, this needs to be addressed and this needs to be taken care of. So any amounts of myopia in our practice at any age under 20 becomes something that we need to be, we consider to be something to be worrying about at our practice, and we intervene. This particular study by Flitcroft really kind of shook me to the core and is making me realize every day that my perspectives as to myopia when I was in optometry school and for the last 10 years needs to be addressed. And this study, it's a great study. I recommend that you look through it. It really has taught us that there is no level or no amount of myopia that maybe is safe for patients to have. You look at the risk factors for glaucoma or a retinal detachment or myopic maculopathy, a 2 to 3 times greater risk factor that those low myopes, even a -1, is going to develop those conditions. This is odds ratio, meaning is how strongly is one condition correlated with another. And what you're seeing here is if you have a 2 to 3 times greater risk factor of developing these, would you really want those conditions? And most people would say, you don't really need to be worrying about myopia until it's at a 4 or a 5. Well, just look at the risk factors for things like retinal detachments and maculopathy. When you get into that 3 to 5 range, nearly a 9 to 10 times risk factor of developing those conditions. And then obviously, I think we would all be on board with anything over a 5. The risk factors for these diseases is substantial. I mean, over a 7, the risk for maculopathy, diseases of the macula, 126 times greater risk. It seems like we're getting to a point where if we miss glaucoma and it progresses and those patients risk vision loss, how is that any different for us to be missing a myope who's progressing, particularly when we can do something about it to slow it down? And not that I'm, wanting any litigation or anything to come against anybody in our profession, but I think it makes us look at this really closely. If we know there's greater risk factors for maculopathy, retinal detachment, glaucoma, I think it's, imperative upon us to intervene for these patients. And so this really shook me to say, I don't want anybody to be a -5 myope. I don't want anybody to be a -3 myope. And if I can slow that down, and at all cost, I want to do that. So we typically think about myopia in kind of 3 different age brackets. And the rate of progression is going to be fastest for the kids who develop myopia in that early childhood, below 6 years old. And this tends to be a substantial eye elongation. And these patients reveal very high risk factors for high amounts of myopia. And then between 6 and 6 and kind of the teenage years, this myopia is a little less progressive, but it's still progressive. And these children may also have some levels of an accommodative work with regards to their development of myopia. And then we kind of have that adult stage myopia. That's kind of where I got myopia in my late teens and my optometry school years, where it was probably more induced by the type of work that I was doing rather than a genetic predisposition. And understanding where things are at will help us to know better how to intervene and how aggressive we need to be. Certainly the big thing is for younger kids. I remember when I was practicing up in Alaska and I saw a change in the myopia for one of my patients, and I said, hey, we need to do something to do visual correction. And the parent was very adamant that we did not want to fully correct their child because I gave them I was the reason why they progressed in their myopia. And at the time, I was not prepared with the studies to show that patients who are undercorrected will progress in their myopia 16 to 22% more than patients who are fully corrected. And what this also teaches me is that if somebody is progressing in their myopia, we need to see them in our practice at least every 6 months, because if they're progressing and wearing the wrong prescription, it's driving the progression to become faster. Now, I think all of us have looked back at myopia control and how myopia has been managed over the last 20 years, and most people believe that rigid gas permeable lenses have slowed down the progression. And I remember when these studies came out, I was just finishing in my residency and doing in my 4th year, and came to see that, gas permeable lenses, when, fit with an apical clearance, they haven't been shown to show much control of myopia. It's kind of just a wash overall. It's showing in the studies a -5 to a -8%. Because there's the flattening of the cornea that may be happening in the perceived myopia management, but as soon as that child comes away from wearing the lenses, it bounces back and then we don't see any progression. One thing that I have to give tribute to my wife is to be thinking about the binocular and accommodative effects that are driving myopia. And I've seen over the years how spectacle lenses can play an important role, particularly bifocals, but I just didn't really understand why or when it was appropriate. We know that there is this issue during accommodation where the lens changes to focus on a near target, and that myopic defocus, if there's accommodation persistent in the distance, and that we see that accommodation, that myopic defocus, which brings about a condition called near work induced transient myopia. And this is the state of myopia that is due to that increased accommodative work. And it's thought to be possibly associated with progressive myopia, which is due to that retinal defocus that occurs when accommodative system cannot relax to baseline. And so we see this as a driver of myopia in a subgroup of patients. So in our practice, what we do is when we have a patient coming in for a myopia visit, which we do not do as part of the standard eye exam, we bring everybody back for a myopia consult if we're thinking we need to do something for myopia management. And at that consult, we do a binocularity screening. And we do a cycloplegic refraction to make sure that we know where their prescription is. And if there's a substantial difference between the cycloplegic and the manifest refraction, we know that there is an accommodative component. We also, before we cyclo them, we do plus and minus 2 flippers at a near target just to make sure that their accommodation is working adequately. And we want to look at that accommodative status and look to see where the posture of the eyes is and whether it's an ESO. If the child fails in any of these, we send them out for a binocular evaluation, because likely in those cases, their binocularity or their accommodative status is one of, if not the main driver of their myopia progression. Now, as a contact lens specialist, that kind of makes sense that we need to do that. And when looking at the studies, there's a huge shift with certain people who've shown progression and help with bifocals. In Edwards' study of 2002, they only saw a 3% reduction. But in other studies, they've seen as much as a 30% reduction with spectacle bifocals. And it may be indicated for patients with an ESO or accommodative dysfunction. In our practice, we prefer to do vision therapy on those patients to help with their accommodation in their binocularity issue. And if the binocular vision doctor feels that it's the appropriate thing, then we will do some sort of contact lens myopia management either at the same time or after the child has finished up with their binocular component. Now, the other aspect of myopia management relates more to an optical consideration with misalignment of that retinal defocus. We believe an ideal optical system is what a camera has, right? There's the flat image plane for the object and a flat image plane for the film, and these tend to be flat. And we look at Smith's research, Earl Smith at the University of Houston, and he's taught us some really, really important things things. We're related to peripheral vision being the driver, and it drives the central refractive error development. So one of the tests that he did is he obliterated the fovea of one eye, and both eyes developed the same refractive error. But when he obliterated the peripheral retina of one eye, then the treated eye became more myopic because that peripheral defocus, that peripheral stimulus was what was driving the myopia. And if we look at an image chart of what's a pretty standard refractive correction, an ideal optical system would be this flat plane, but the retina isn't like that. More often than not, we have this hyperopic defocus that causes this misalignment here in the mid-periphery, as my cursor is indicating. And it's because of this misalignment between the mid-periphery peripheral retina that's driving the retina to elongate. And that's leading us to understand more and more of why the eyeball elongates. Interestingly, Emily, who is the resident at Pacific University, presented some data at the Global Specialty Lens Symposium about, well, what are soft contact lenses that a patient is normally wearing do to this? And the reality is that they may be inducing, and for most people, maybe driving more peripheral hyperopic defocus. Look here at the right-hand side of the various different lenses at the various different powers. And if you look at the power profile of most contact lenses, you're going to see that from the central 0.5 millimeters out to the periphery, most lenses have more increased power, which is driving more hyperopic defocus. So it's almost as if the soft contact lenses, which are correcting the central vision, the higher the amounts of myopia is creating more of a hyperopic defocus and potentially driving more of our patients to become more myopic faster. Now, this certainly isn't the purpose or the reason why these contact lens companies are making their lenses that way, and they don't necessarily make their lenses with the intention of helping with peripheral defocus. But if we as clinicians realize that both for soft contact lenses as well as spectacles, we may be driving more hyperopic defocus, we may be driving our patients to become more myopic, not realizing that it's happening. So historically, we've looked at, under-correcting with gas-permeable lenses. Modern myopia management after or outside of the binocular accommodative issue has really looked at atropine and soft multifocals and ortho-k to kind of help this slowing down of this myopia progression. And there's some great studies that look at all of this. I want to briefly go over several of them. Most of you are pretty aware of them. The ATOM 1, 2, and 3 studies came out. ATOM 1 was a 2-year study that showed a 77% reduction in the progression of myopia, but unfortunately, with a high concentration of 1%, there was a lot of side effects, and there was this kind of rebound effect where patients became more myopic after they stopped using it. So then they did another study where they used a lower concentration of atropine, 0.01. This was a 5-year study that came out in 2016. And the children who had myopia progression, during this study, during the phase 2, started the second phase of it, where they used 0.01 for an additional 24 months. And over the 5 years, they found that this concentration discussion really revealed that a 0.01 was kind of the best concentration for slowing myopia progression and axial length. And more recently, we've kind of come to this question are we sure? Is that really the best concentration? In a study that was started in 2017 for the ATOM 3, we're looking at this higher risk children that were randomized into utilizing atropine or placebo, and it was going to be a 2-year 2-year study with a 1-year washout and look at whether low-dose atropine really is effective. Meanwhile, there was another study that was called the LAMP study that looked at the concentrations of 0.05, 0.025, 0.01 atropine. And in this particular study, we've kind of come to a conclusion that maybe it's not 0.01, maybe it's a higher concentration, 0.05, that we need to be looking at for our myopia patients. And I think the walk away that we have from the atropine discussion is that if you can get your patients utilizing some sort of atropine, they're likely to reduce their progression. What's the right concentration? I think we can get 10 myopia management experts into a room and have some heated discussion about it. In my practice, we really are okay with 0.01 or 0.05. Our standard now has changed to 0.05 as the concentration that we are using for our patients. Soft multifocals are a good option because they can show 29 to 45% decrease in myopia progression. There was a study that CooperVision did on a lens that they have outside the United States called MySight, where they released this last year, and they showed a 52% reduction in the progression of myopia for patients that were using it. This NatraView lens has been broadcast as a lens that's a good option because it's a daily disposable and it goes to high powers. It only has one ad power, so it's a relatively simple lens to fit. It doesn't come in torics. And overall, we know that soft multifocals may be a good option for certain people. We prefer in our office not to use them on super young children because a 5 or a 4 or a 6-year-old may not be as comfortable taking a contact lens in and out every day, and the parent may not be as comfortable having their child go to school with it. If it's not a daily disposable, then they have to clean it, and we have concerns about hygiene and so forth. So soft multifocals certainly play a part, and if you're doing nothing for myopia management, I would highly encourage you to consider it as an option. But you know, it has a place. Now, I want to speak a little bit for a while about orthokeratology and how we see orthokeratology in our practice. I remember when I was at Pacific, and I remember having the conversation after Pauline Cho's kind of initial study came out about the benefits of orthokeratology for our myopia patients, and how excited I got to realize that maybe there is something we can do to help slow down the progression. And I was fitting a lot of ortho-k in my residency, working with Pat Caroline, and you know, came out of that, you know, trying to be the best ortho-k fitter that I could. We know by looking at an image shell that because of the type of refractive correction, we're working to fix that hyperopic defocus by bringing in that peripheral image. And you know, there's some great lenses that are out there. You know, we've used all of these lenses. There's a lot more than just this, but if you're new to ortho-k, just realize there's 3 major types of fitting. The empirical fitting, which is Euclid is, you know, the #1 empirical fitting lens that's out there. Topography driven, where your topography really is driving you as to what lens you're going to change your patient to. And then diagnostic fitting, which is what Paragon has really led the market with. All 3 of these are great ways of doing it. Each practitioner has a different way that they may choose to go about their fitting process. Like I said, we've done all of them more recently, and not to be a commercial for Euclid, is the empirical fitting just has been so much more effective and more simplified that we tend to go with the empirical fitting more frequently. As we look at ortho-k as a percentage in different countries, places like Hungary, 25% of their contact lens wearing population is wearing ortho-k lenses. And in places like China, 61% of all contact lens wearers are using orthokeratology. And this is just astonishing. And it comes to this realization is what's wrong with the United States? You know, only about 2% of all contact lens fits in the United States are ortho-k, but yet 50% of the population is myopic. I mean, we've got got a major disconnect here in the United States, where places like China, where nearly 90% of the population is myopic, they've got a far more correlation, and they're seeing that. And the practitioners over there are, seeing the benefit of it. Something that reinvigorated me was this particular study, and this study is called the SMART study, the Stabilizing Myopia by Accelerated Reshaping Technique. And the 3-year results for this particular study showed that the soft contact lens group progressed in their myopia by a diopter, whereas the ortho-k group progressed by 0.13 diopters. This is a huge percent change between these groups, but I think more stimulating than just the outcomes for this, because we have other studies which show great results with ortho-k, is that in the group that did orthokeratology, they had a huge first fit success. In this particular study, I believe 8 out of the 10 sites had not used the emerald design before doing this particular study. So, when you do study, you do research, it doesn't really matter what you've used in the past. You just follow the protocol, and the protocol really drives you. So you don't have to be a super great clinician in this way or that to do a lot of research, because you're very protocol driven. And in the study, I believe 8 of the 10 sites had never fit the emerald design. And what was astonishing is that they found 80% first fit success with the first pair of lenses. And if they needed to make a lens change at one of the visits, they found that 80% went up to 95% success. And the second lens change, if it was needed, went up to 99%. And I think that really that hit me in the head and made me kind of realize that maybe we need to relook at how we're doing orthokeratology, because I'm sure, like many of you, sometimes you're seeing patients with your diagnostic fitting or your topography fitting 2 or 3 or 5 or 10 times to try to get that lens fit right. And really, we need to be looking for things that are simple and that work really well. So the way that this particular study looked at things, and this is how we fit the emerald lens in our practice, is you just have to report on whether what the Ks are, the RXs, and the HVID for the patient. And it's as simple as that. You get those 3 measurements and you send them into the laboratory, and then you dispense the lenses and see them back. Obviously, you want to make sure that it's healthy on the eye, and everybody has their protocols for that. But you see the patient back, and it's as simple as that to know whether the patient is successful. And I think as clinicians, what we're always striving for is, how do we gain success and improve the success in our practice? And so I'd like to share with you 5 quick tips that I've found have kind of reinvigorated and restarted my ortho-k practice. Again, we've been fitting lenses for 15 years. Largely over the 15 years, we've fit the Paragon lens, and then I switched over to the empirical fitting a couple of years ago because I found that the success rate was a little bit better. But I think as we sat down, and we have a residency here at my practice, and we sat down with our resident and the other doctors in the practice, we all kind of sat down and we said, when it comes to ortho-k fitting, what's our number one goal? And we need to make sure that our number one goal, if we're doing it for myopia management, is actually the correction of myopia. And I found that what I was doing is I had patients who came in who were 20/25, and they were reading 3 or 4 letters on the 20/20, and then they were complaining that maybe they had some halo, and they were noticing that maybe their vision wasn't as crisp, and if I made this lens change, I would be able to make a huge improvement for them, or this lens change. And I felt like I was just always chasing my wheel. Chasing my tail, excuse me. And when we sat down and we started looking at the studies, a lot of the studies have these children, 6, 7, 8 years old, seeing 20/25, 20/20 vision, and the myopia control is great. It's working. And so we went back and we said, let's revamp what our number one goal is for our patients and to communicate with them that even if the patient doesn't have perfect vision, we're still achieving our number one goal. And the number two thing with the quick tips is to find success early. First of all, what that means is that we need to be doing orthokeratology earlier on in our patients. And to me, I'm comfortable doing orthokeratology on a 5, 6, or 7-year-old. Maybe not you, maybe you're not as comfortable with those younger kids, but I find that if they are myopic at those earlier ages, they're far more likely to progress. And I'd much rather start doing myopia management on them when they're super young than wait until they're a 2-diopter 8-year-old when maybe I'm feeling more comfortable with 8. And so we find success earlier. It's also simpler to do orthokeratology on a -1 than it is on a -4. And so we want to go for it on those earlier stages. And then if you haven't done ortho-k, which about 50% of you have, start with your low myope. Start with your -2 or -3 patients, your -1s, and start getting some reps on seeing what success looks like before you have to do much troubleshooting. If you're using an empirical design, you may be successful 80%, 90% successful with that first set of lenses, or that maybe if you get one lens change. And then you can progress your way up from doing -1, 2, 3 to that -4, -5. I've done as high as a -10, and let me tell you, it doesn't work perfect, doesn't work great. The patient doesn't see super, super, super well, but you can do into those higher ranges. And if the patient has a lot of cylinder, you need to look at whether it's limbal cylinder, or if it's more central corneal cylinder. And if it's more central corneal cylinder, you may be able to get by with a spherical type of design. But if that astigmatism is ranging to the periphery of the cornea as seen on a topography, you may end up needing to do a toric type of fit, which still can be done empirically, or you can do it with a diagnostic type of lens fitting set. Then the next tip, which really shook me and made me realize I was looking at the wrong thing, and I'll give props to my resident Andrew Fisher, who really helped bring this to my awareness, is to shoot for smaller optic zones. Again, a poster that was done at Pacific University, Randy Kojima led the charge on this, looking at topographies, showed us that a smaller optic zone really is the smarter way to go. And this makes perfect sense. Look at the profile of the eye as you look across the lens, and you can see with the image on the left how the add effect is a 1-diopter add. Well, we know that the hyperopic defocus is reduced if we get a higher add. That's why we use multifocal soft contact lenses, right? So if you're using a smaller optic zone, which will then give a higher add effect to the patient's eye, you very likely will be getting a better effect from an orthokeratology perspective. There hasn't been a ton of research on this, and certain lens designs are locked in on the optic zone and you can't change it. One of the things we like about the Euclid optic zone is it's a little bit of a smaller optic zone, so it allows us to maybe have a little bit of a larger add power for those myopic patients. And if you have a patient where they have, they're an adult and they're getting glare, you may want to go and ask the laboratory, can you make that with a little bit of a larger optic zone so that you get less of that add or the distortion effect? I remember during my residency, my residency project was to look at the aberrations that were induced from orthokeratology, and they're there, and that's why we have distortions and glare and halo for some patients at night. But when it's a child, we aren't as concerned about those things because they're not driving, and when they're playing sports and everything, they're outside, their pupils are smaller, and they may not be getting as concerned about that. But when they're in school and the pupils are a little bit larger, then that add effect really comes into play. So I think that's a big one that is oftentimes missed by many of us. And then the next thing is the full correction is not needed for us to achieve our number one goal. A study that was done out of Pauline Chu's research facility showed that high myopia, when a patient has higher myopia, even 5 diopters, a partial reduction can even help to slow it down. And in this case, axial elongation was 63% slower in partial reduction ortho-k patients treated compared to single vision spectacles. That's fantastic, right? I mean, we want to slow down the axial length progression. And if you're only correcting a portion of it, you're still most likely getting some of that hyperopic defocus alteration to the retina. And so you're still getting it. So if you have a patient who comes in and they're a -5, a -7, and you're like, man, that's really high, I don't know that I can do full correction ortho-k on them, just know that if you target a lower amount, say that patient's a -7, and you try to correct 4 of it, then you can simply give the patient spectacle lenses to correct the remainder of it, as this study pointed out to us, and we still get the effect. So understanding that number 4, full correction is not needed for us to get our number one goal of myopia management. And I want to really push that out, because I think so often when we're doing ortho-k, we think, oh, we got to get perfect vision. We've got to get 0 prescription on the over-refraction. And just realize that if you have cylinder, if you have additional myopia, you can correct that with spectacle lenses and still achieve myopia management. And then the last but not least is it's okay to do combination treatment with atropine and orthokeratology. A study that looked at the combination of these treatments found that dual therapy was more effective than monotherapy. 2.1 times less progression in the ortho-k group alone versus 2.6 times less progression in the atropine progression than atropine alone. So that dual therapy, that 2 times greater, I think I said that wrong. Let me rephrase that. There was a 2 times less progression than the group that did ortho-k alone, and a 2.6 less progression for the dual therapy versus atropine alone. So combining the treatments has almost a doubling effect. In our practice, we do use atropine in combination with ortho-k, but usually we get our patients into ortho-k first, and if we're getting a cessation or a significant reduction in the progression of their myopia, we don't add atropine. But if we do see that they're continuing to progress in their myopia, we add it in. Or if the patient is really young and they're progressing very quickly, we may add it in as a dual therapy even sooner. So we've got some great studies that are validating orthokeratology as a great way to slow down the progression of myopia. And also, I want to point out some really good resources. Just take a screenshot of this, and you'll see that the myopia, managedmyopia.com, or the myopiaprofile.com. Those are great sites that have incredible content that you can help share with your patients, a lot of statistics that are on those sites. And then the calculator that Brian Holden has put together is really cool. I actually just whipped this out for a patient the other day, and you can show the amount of myopia that the patient has. So here's Kate Giffords from the Myopia Profile. You can see that she's got this profile that you can print out and show the genetics, the characteristics, the eye teaming, and so forth that drive towards the myopia. The myopiaprofile.com, another great resource. And then on the Brian Holden site, they do a really good job of indicating how to really boil down myopia based upon the child's age, the child's refractive error at current, and what method of treatment that you're going to use. So in conclusion, I think we just need to realize that myopia is a lot bigger deal. And I think we can all do better at that. Every time I lecture about this, I try to become more effective and hate myopia more, understanding it is a disease and we just can't let it go by the wayside like we used to, particularly for kids. It's on the rise and it's happening more often. If you haven't hired somebody in your practice to do marketing to get this word out, get somebody in your office to help share with your patients and share with the public that myopia is on the rise and we need to work to stop it. My question to you is, what are you doing to stop myopia in your practice? If you're not doing anything, tomorrow it's simple. Take Ks, RX, and HVID and send them in. Start fitting a soft multifocal. Consider atropine in your practice, but do something to slow it down. What if you could be successful with 80 to 95% of your ortho-k? Let me tell you, that's higher than most of us are with our soft multifocals, but yet we all embrace soft multifocals for our patients. But if you could be 80 to 95% successful, what would that look like? And just don't give up on these kiddos, right? There's a huge issue that we're needing to be addressing. And if we make the changes today, we can be affecting these patients' lives for a lifetime. So with that, I think we can jump over to some questions and answers. And I'm not really sure how we're going to be going about these questions and answers. But is this something, Jane, you want to spearhead, or how do you want to do this? I'm not hearing anybody jumping in, so let me see if I can look at some of these questions. Do you use proparacaine at dispense of the ortho-k lenses? The answer is I do if I see apprehension with the child, but I don't if I feel that the kiddo is going to be able to cope with the level of adaptation. There was a great study that was put out in the early 2000s, led by Ed Bennett, and they looked at the success rate of contact lens dispenses if you did use proparacaine being higher. But I find with ortho-k, if I can get them to put the lenses on and close their eyes immediately, it gets over that initial concern. Against the rule or with the rule cylinder, incidentally, you can do both as long as you're able to get the lens to sit correctly. So you can do both with toric lenses. Obviously, it's easier with the rule, but that's that kind of comes down to working with the laboratory, and really you should have a good laboratory working with you, and that helps you be more successful. I see a question here: is 2025 the metric for quote unquote success? My response to that is no. Management of myopia is the measurement of success, and if I get a patient who's a -7 to 20/40, and I can correct the rest with a contact lens or a pair of glasses, to me that's successful. I want success to be that we're slowing the progression of myopia down.
Dr. Kading?
Yes.
Laura?
Hey, Laura.
Over in the Q&A section on the bottom of your screen, we've got about 12 other questions so far. One of the questions is, let's see, over what period of time is the increase of minus a half considered progression, and is that age dependent?
Can you say that question one more time? Over what period?
Over what period of time is the increase of -1/2 considered progression, and is that age dependent?
Yeah, good question. So over what period of time do we think that a half a diopter progression, and is it age dependent? That's a good question. So if you have a child who is a -6 and they progress by a half a diopter over the course of a year, that's actually pretty good. Most kids in that age group are going to be progressing far faster than that. Um, if you've got a 12-year-old and they were, plano and then they became a -0.5, I may not be as aggressive on that as if I have a myopia progressive patient who progresses every single year. So is it age dependent? Kinda. Older age, I'm not as worried about a half, particularly if they're a low myope. But, if a patient has been progressing, and then they slow down to a -0.5, do I still want to try to slow it down more? Yes, I do. I see here, what's the most common?
Oh. Dr. Kading? I think we lost your audio.
Oh, can you hear me now?
Yes.
Okay. So what's the most common ad effect when doing ortho-k? I see is another question here. And I don't know that we necessarily know the answer to that. Do we, Andrew? The most common ad effect? I think we're learning about that more and more. And I think it kind of depends. It's different with each patient. Smaller optic zones will bring about a higher ad effect. Andrew's my resident. He's sitting here with me. So what's the typical cost of compounding atropine, and is there a medical insurance that will cover it? I can't speak to that because I think it's going to be different everywhere around the country, and I'm not really sure that you're going to get insurance to cover it, but I'm going to leave that to you in your area. How often do we use atropine? I'd say maybe 25% of the time, maybe a little bit less than that. It kind of depends on the patient. I think we're becoming more comfortable and more familiar with it. We've used it more in the last year than in the last 3 years. Next question is, do you take axial length measurements? If so, and then the question bugged out. So to answer the question, we don't take axial length measurements. I would love if that was possible. Some newer instruments are coming onto the market, which are becoming more mainstream for more mainstream optometrists. The reality is that axial length measurements are the gold standard. But I just don't think we're going to get there anytime soon. We're not going to get every practitioner to use an axial length measuring device as quickly as we need to get every practitioner doing myopia management. And so I think that we're going to be managing it more based upon the research and more based upon refractive error. But if I could, I would, but I don't think that it's realistic for everybody to have an axial length measuring device. We probably will in short order here, but we don't currently. The instrument that's kind of becoming more mainstream that we would be using for that is there's an Oculus machine, the Pentacam, which is becoming more mainstream with regards to that. And then obviously, an IOL type of master. Can you still have success with 20-something-year-olds? Sure. Yeah, if they're progressing because of a hyperopic defocus, the answer is yes. I think more often than not with 20-something-year-olds, their driver of their myopia is probably more accommodative than anything else, but you could do that by doing that binocular vision screening that I said. Once you start ortho-k on a patient, are they pretty much on it for life? How excited are you with over 18-year-old patients about the visual outcome with ortho-k? I have a lot of patients which would fight me if I tried to take away their ortho-k lenses when they reach their late teens and adulthood. Because they love wearing lenses and not having to wear them during the day. I find that some ortho-k patients are super stoked about their vision, and they, might wear them every 3 or 4 days and find success, and maybe they slough off to 20/25 vision and they're still happy, or 20/30 vision and they're still happy. I had one patient who went into his 50s, and depending on whether he needed good near vision the next day or great distance vision the next day would indicate to him whether he would wear lenses in both eyes, every day. So different patients will work different ways with it, and absolutely, I think you can do it into adulthood. How do you start the conversation about myopia with a group of patients? So I share with them that myopia is common, and myopia is becoming more common, and that we're realizing that myopia is now has high risk factors of disease. And, Brian Holden really kind of brought about a realization and made me start thinking about this and kind of challenged us in this way. Can you think of a -7 myope in your practice that is over the age of 60 who doesn't have retinal disease? I can't. I have one that sticks out in my mind very, very well who was a -10, and we did great. I mean, he was in his 50s and he was rocking. He hit into his 60s and he just started having all sorts of issues. But how many -7 myopes can you think of that don't have any retinal pathology? So we share with our patients that the risk factors are very high. Your child is right here, right now. And if you pull up that calculator that Brian Holden has, you can show what the likelihood that the patient will progress to. So I think there were some great questions. If small amount of myopia after ortho-k, what type of contact lens would you use? I would probably use a spherical soft contact lens or a toric if there was any residual sil. I don't think I would fit. I think the question's probably alluding to would I fit a soft multifocal, and no, I don't think so. I think you could use, because the study that Pauline Cho did, she looked at single vision spectacles. So I think a single vision lens would be okay. It may be countering a little bit of that hyperopic defocus, but so do spectacles to a degree. So Dr. Brill asked a question of how do you discuss the goal of slowing the progression of myopia down versus seeing perfectly with a patient who wants copies of their record at each visit? So Dr. Brill, I think this is a brilliant question, because I think we all have those patients who want the perfect vision. And I think it's somewhat funny when we've got a patient who comes in and they're 20/50 with their spectacle lenses at their myopia consult, and then you get the child to 20/25, but because you're not getting them to 20/20, the parent thinks that it's an absolute failure, whereas you've just doubled the clarity of vision that the patient saw. So I just become really adamant with the patient is our number one goal is the management of myopia. And if we need to, we will correct the rest of the prescription with spectacles. And the studies show that that's effective. And if somebody's not able to get over that, then I think it's probably okay if they go and find somebody else to fit their lenses. I don't push them out the door, but there is a point where we may be only able to get with some patients. That's not common, but sometimes that's the best you can do is 20/20 or 20/25. So I'm going to do one more and then we'll be done because it's after 6, after 9 o'clock for you Easterners, is how do you monitor whether there's progression after a successful ortho-k fit? Well, you record the refractive error that you get with the ortho-k lenses, and if it's plano or -0.5 or +0.5, whatever it is, and then you see the patient back for an eye exam in 6 months or a year and check the refraction. I know that there's some clinicians who find it valuable to to actually wash out their patients every couple of years. And I think that's a great way to go. We try to do that with our patients, is to do a washout every 2 or 3 years to really kind of look at where things are. But it's kind of going to be up to every single person. Cycloplegic refraction is obviously the gold standard beyond an axial length measurement. And then last question is, what methods have you used to market this? Well, I'll tell you that we're continuing to learn about marketing. We have a dedicated marketing person in our practice to try to grow our myopia management, our dry eye, our binocular vision, and our keratoconus. And one of the things that we do is we do an all-day educational course for all of our referring doctors, and we teach them how to do myopia management. And then hopefully they're doing it and they're helping impact their patients. But if they're not doing it, then they know that we do it and they can refer to us. We've also done in-office seminars, and you can do that with either a group of patients and welcome, say to your ortho-k patients, hey, we're putting on the seminar. If you know of anybody who has questions about orthokeratology, we would love to invite them in, and they can learn more about myopia, because it just seems like in certain populations they know a bunch of people, and if you welcome them in and share more about it, it can be helpful. And then the other thing is, if you're doing some sort of myopia management in your practice, I would encourage you to reach out to 5 or 10 clinicians who you know are not doing myopia management, and maybe invite them into your practice and teach them about myopia management and why it's important to do it. And one of two things will happen. Either those people will start doing it and we're going to impact more patients, or they'll refer those patients to you and really help to grow your ortho-k practice. So with that, I'll sign off. Thanks for everybody for sticking around a little bit late. I really appreciated all of you coming on board. And again, thank you to Euclid for making this possible. I really appreciate the opportunity to share. And if any of you want to reach out to me, you can do it through any of my social channels, which is at optometricinsights.com, or you're welcome to email me at dave@optometricinsights.com.